I'm Elizabeth Sullivan. I'm the AIA Design for Health Co-Chair Committee member, along with Manjuria Paprikar, who I do not see here, but we're really thrilled to co-host this event with the AMFP Advocacy Committee. So I'm not gonna do anything more. I'm gonna turn this over to Lizzie. But thank you all for coming. There is an AIA sign-in. We're going to pass this around a few of them. So if you need credits, the credits are still pending. So please sign in if you want a certificate.
Good morning. I am so happy to be here. I'm so glad you all are here. My name is Lizzie Archer, and I am an assistant vice president with McKissick, a construction management firm. About a year ago, I took over the advocacy committee for the AMFP chapter, and I asked the health system friends I know, what would you like to see the advocacy committee do? And they said, we would like to get to know the regulators better. The Department of Buildings, FDNY, Con Ed, you know, Department of Health. And so we spent a year sort of reaching out, establishing initial conversations, having little virtual chats. And here in 2026, we are able to have this event. And getting approvals for public speakers is an art form in itself. And we were able to finally just coalesce. And we have first speaking our new Department of Buildings Commissioner, Ahmed Tigani. And I am going to introduce him. I'm so excited. Ahmed Tigani is the 27th Commissioner of the New York City Department of Buildings. As Commissioner, Ahmed works across the agency's divisions to advance the agency's mission and objectives. 2, foster collaboration, ensure operational and programmatic alignment, and my favorite, strengthen partnerships with the external stakeholders. That's us. In order to ensure DOB is a thoughtful steward, driving building safety, efficiency, and innovation in one of the world's most dynamic urban landscapes, New York City. Prior to his appointment as DOB Commissioner, Ahmed served in several roles at the New York City Department of Housing, Preservation, and Development, including Acting Commissioner, Deputy Commissioner for the Office of Neighborhood Strategies, and my favorite, Chief Diversity Officer. If you saw his clap out video at the end of his time at HPD, you would have seen the staff crying and taking videos. The commissioner was crying, and I, watching the video, was crying. It was very emotional. It was a joyful story. Commissioner Tigani went from being a boys who family needed housing to being a man who provided housing. Now, I'm going to lay some numbers on you. But before you zone out and start scrolling on your phones, I want you to envision a person or a whole family to every single number I share with you. This is what it means to have a real impact on people's lives. During his leadership at HPD, the agency achieved significant outcomes, including placing 13,000 formerly homeless households into permanent affordable housing, approving 31,000 housing lottery applicants, issuing 6,600 housing choice vouchers, completing or attempting 2.4 million housing maintenance code inspections. Financing or preserving 44,000 housing units, 5,000 units of which were Mitchell-Lama units in fiscal 25 alone. Since 2021, the agency also completed 70 ULURP. I mean, that process is long and hard, or discretionary actions that facilitated or will facilitate the construction of nearly 5,000 new housing units. On On top of that, Commissioner Tigani is no stranger to the Department of Buildings. Earlier in his career, he served at DOB as Chief of Staff to the Commissioner, where he was responsible for streamlining operations, accelerating project review. That's what we all want. Increasing transparency and developing new tools to enhance construction and tenant safety. In this role, he also helped the agency navigate through COVID-19 pandemic. Oh my gosh, I don't know how he did it all. Ahmed previously served as senior advisor for housing economic development. Without economic development, none of this happens. And the labor in the mayor's office of intergovernmental affairs during the de Blasio administration, working on neighborhood rezonings, legislative priorities, and major development projects. Now, some of you hospital folks are developing major projects, and this is your man. He is going to help you do this. Before all that, he worked on community development, housing policy, and land use issues in the office of the Manhattan Borough President and in the City Council. Ahmed is a proud alumnus of CUNY Hunter College. This is a person of this town, for this town, and it is an honor to have him with us here today. Please join me in giving Commissioner Ahmed Tigani a warm welcome.
In my short tenure, that may have been the most kind introduction anyone has given me, including family, including people who are my blood relatives. Good morning, everyone. I am just really excited to be here. I want to thank Elizabeth and Lizzie for thinking of including me in part of this event. I really think it is wonderful that AMFP and AIA are holding events like this, inviting your government partners out to get to know you and be part of the work that you're doing on the ground floor in the trenches. You know, events like this help to strengthen the relationship that's so critical to ensuring that your organizations receive the support that you need to operate successfully, and that government secures the very sought after compliance, but more importantly, that we think about compliance in a way that's achievable, and that our regulations are relatable to what the reality is that you see in the communities and in the buildings and in the structures that you manage. Our healthcare facilities here in New York City, represented by all of you here today, and the medical institutions they house, are a marvel and a world-class core element of what makes New York City a place where people can live, work, and thrive. I mean, the city is truly blessed to have close access to the world-class medical facilities that you all make possible, the medical care that your colleagues provide, and it serves as an unambiguous good for New York City. But it is not lost on anyone who does this work that you face a myriad of challenges, dealing with ever expanding needs of an aging population, rising costs across the board, and partly responsible, a complex regulatory environment. So as DOB Commissioner, I see my job in part as balancing the needs of various groups, working to support public safety, compliant development, and of course, quality of life. For the healthcare industry, those needs include having a guide to navigating the regulatory framework in which you are required to operate in, but you also can maintain your facilities, expand your footprint when needed, and make building alterations to support your staff and patients, but we need to be able to show you how to do that. We need to use language that's clear. We need to be able to be accessible, and we need to figure out how to do that at different hours, meaning in person when you need us, online when we're not available. The mayor has been clear about the priorities of this administration. Our city faces twin affordability and housing emergencies, which makes life in this city unattainable for too many. When you dig down deep enough, many of these high costs are tied to scarcity in places where we live, work, and operate. And that scarcity is not helped one bit by how difficult it can be to build in our city. I know full well how frustrating it can be to get all of the ducks in a row, to get a project greenlit and shovels in the ground. As was mentioned earlier, prior to becoming commissioner at DOB, I served as acting commissioner at HPD and first deputy commissioner and commissioner of the Office of Neighborhood Strategies, where I spent a lot of my time thinking about how to make the bridge between the developer, the design professionals, the community advocates, the program partners, and the city. How do you make that bridge work so that everyone is contributing, everyone's talking to each other and hearing each other and getting those projects up, particularly affordable housing projects, but many of them also were mixed use projects. We had the entire neighborhood plan in Bed-Stuy anchored in community wellness and health. And so it meant that people wanted affordable housing, but they were not going to let the city build affordable housing without thinking about how you use the ground floor and second floor spaces to make their community more healthy. In my new role and under the mayor's direction, I am now focused on speeding up the development review process from inside of DOB, a benefit to anyone who wants to help New York City grow. If we can make it simpler to get projects up and running, we can help create jobs, grow economic development, and spur the creation of new buildings and new spaces that the city desperately needs. But make no mistake, improving the development process doesn't mean safety takes a backseat. Protecting the public, which you all know very well since you do it in other ways separate and apart from construction, will always be our priority in government. And we are not going to stop pushing for safer job sites. The last thing I want is for builders to cut corners on the work in the name of expediency, leading to workers taking a trip to one of your emergency rooms. I know that the goal of speeding up development process, promoting public safety are not at tension with each other. We can have our cake and eat it too. So when one of you in the room needs to make changes at one of your properties, I want to make sure that you have the permits and inspections you need to facilitate that work. Despite what some in the development and real estate world might believe, DOB actually wants your project to succeed. I think that the disconnect comes down to how the department has communicated with the public. We need to do a better job of communicating with industry, showing them that different programs we have that can assist them gets them a code-compliant application process. And I'll say this a couple of times. I think it's important for people like me and the senior staff at DOB to be in meetings with folks like you, to be available to you, to come and be able to talk to you even before the ideas are set, to figure out if we're in the right direction or wrong. We may not always agree, but avoiding the conversation guarantees that we won't be successful or the way that we want to be successful at the end. My best piece of advice on these projects to everyone in the room is to engage with us early. Reach out to us as soon as you can in the planning process, which is going to pay dividends later when you encounter less surprises and we are disrupting your timeline less. For reaching out early, a consultation with our development hub at 80 Center Street is a good first place. Thinking about making big changes at your property, I would strongly encourage you to check out DOB's Major Projects Program, MPP. This is a voluntary program offered by DOB, which provides dedicated service and guidance to streamline complex, multifaceted projects. Participants who enroll in the program start getting one-on-one help before they file an application, and they continue receiving that level of service all the way to letter of completion and certificate of occupancy. By signing up for MPP, you can help solidify your timeline by getting the help early that you need to successfully navigate the plan, the exam review process, and avoid common site safety issues that lead to damaging stop work orders. If you're thinking you need help with a smaller project, request an appointment with one of our project advocates. They can help you orient your project onto the right path and help your design professionals avoid pitfalls when filing an application. My goal is to change the perception of DOB. We shouldn't be seen as an obstacle for projects, but instead as Sherpas, Sherpas, showing you the way to navigate the city's application process, resulting in approving projects that comply with the city's code, helping you meet your timelines, and meeting the needs of your organizations. The mayor has been strongly supportive of this goal. We have been talking about the resources that we need to make this a reality beyond the success that we've already have. I'm excited that in the coming months, we'll be making additional announcements on ways the city plans to improve service levels and simplify the development process. And I can sense that some of you might think that this idea of new changes coming is something that you've heard before, and maybe these changes might be moving at the speed of government. But I have seen our new mayor at work in these past 6 weeks. I have personally been able to see immediate decisions like the approval of supportive housing projects, the advancement of new programs to help at-risk youth, the ability to appoint and get people in place who are experienced and helping us fight back against issues around emergency fires and incidences during this cold snap. I can tell you that he likes to move fast. He wants to build on successes that we've had in recent years, and he wants these successes to be done in collaboration. He does not want this to be a top-down exercise. I'm proud of the city's efforts in the last couple of years to modernize the way we look at zoning and building. I was very honored to be part of the City of Yes initiative back from when it was part of the city's Fair Housing Plan in 2020, and then it took shape in a set of zoning amendments that you saw over the last couple of years. This was spearheaded by our colleagues at the Department of City Planning, and through their success, particularly in the City of Yes for Economic Opportunity, we saw text amendments that changed specific provisions in the zoning code related to life science and laboratory facilities. Text amendments that were introduced did away with ambiguity in the city zoning for life science activities, making these facilities as of right, which, as you know, means saving a lot of dollars in most commercial districts around the city. The rules broaden the applicability of scientific research and development facility special permits so that commercial labs can be set up near hospitals and universities in more areas of the city. These are changes that opened up more of the city to these types of medical facilities and laboratories, clearing unnecessary and outdated hurdles. Partnered with the investments of capital and available grants and funds through the Economic Development Corporation, these are changes to improve the development process to better utilize city subsidies to invest in this work, and shows that the administration is committed to reviewing every part of our process to determine what other changes can be made to reduce timelines, cost, and get the best bang for our buck on the public side. You can't talk about city regulations without talking about Local Law 97. I know this is top of mind for many of you here. The city law, which places strict limits on greenhouse gas emissions on larger buildings around the 5 boroughs, hits many of you in a very particular and sometimes unique way. The first reporting deadline for the law just passed in December, and I am really pleased to announce that over 90% of the buildings covered by the law have filed their required annual reports and showing compliance. For buildings that haven't submitted reports, we're mailing out notices of deficiency, informing them that they should continue to work with us, but there are consequences if they don't. But our Sustainability Bureau is not there to inflict warnings or cause fear. Our Bureau is there to work with our partners on how we can further support getting buildings to decarbonize and become more environmentally friendly. I think this is particularly hard for high-intensity energy users like hospitals. You have a unique challenge under the law, operating round the clock with a significant amount of energy usage for medical equipment. DOB recognizes this, and the law recognizes this. This is why DOB is providing building owners every opportunity to work with us on compliance pathways. For nonprofit hospitals, the law offers opportunities to get adjustments to your carbon emissions limit, which is something DOB can help with. We also stood up a series of working groups so that we can study how we can further support building owners to decarbonize buildings. And we are looking to take some of that material, take some of that analysis that we do, and see how we can improve Local Law 97. I do and want to mention our friends at Northwell Health. They're part of this working group, and they're helping us look at facilities using efficient cogen equipment that both powers and heats a building, and how this should be factored into the Local Law 97 equation. My goal for Local Law 97 is to make the law as effective as possible. You know, I have a young son, 7. I make a lot of decisions for him, naturally. Not all of them, he makes some his own. But I do get worried. I see what's going on. I recognize through data and news articles and hearing speakers on this topic. I want to see, in addition to making sure people have affordable housing, I also want to make sure that I'm doing a little bit to make sure the earth is rolling around and working properly for him when he gets, to the adult, when he becomes an adult. So this means something, but we can't do it if the law doesn't allow you to comply. So I really appreciate Northwell, I appreciate others who have chimed in, and I look forward to working with this organization and thinking about what the future should look like as we work to decarbonize and green our city. So, my first day at DOB was about 3 weeks ago. It was a return, but I left a DOB that looked very different than the one I came back. I have since packed my calendar with back-to-back meetings on a wide range of topics, but even so, I told my executive team on the first day that we need to make a point to carve out time in the calendar so I can continuously be engaging with industry and coming to events like this. And I hope this is not the last time I get to speak with this organization and talk to you about what we need to do. I truly believe in the importance of the partnership between the regulators and the private sector. Our city faces so many challenges, the ones that government can't solve alone and private industry can't solve alone. So let's just solve it together. Meeting face-to-face in settings like this, I can listen to your ideas, find out what's working, find out what's not, and we can figure out where to move the needle in the right direction. I am very excited about what kind of new technology, what kind of new footprints, what kind of new design makes the 21st century healthcare facility. And so I want to express my gratitude in advance for what those conversations will look like. And I want to thank you for giving me the opportunity to speak with all of you here today. And I hope you have a great rest of your conference. Thank you.
Our next speakers are Frank Cicero and Toyin Gandeli. If you two would mind coming up and taking your seats.
You want us to just start in? Let's see what Lizzie says. Would you like us?
So this group here is wonderful from the department. Well, Toyin he's affectionately known as Toyin. I hope you don't mind me saying your nickname. Everyone calls him Toyin. And he is a level 4 specialist in survey and inspection for the Department of Health. And I hope you have the handouts because it has a detailed bio of Frank Cicero, who's legendary. When we were discussing this at the committee, everyone was like, well, do you know Frank Cicero? He's like a Department of Health whisperer. And so I'm so glad he could come together with Toyin. They know each other. I believe you've worked together on, right. So, and Toyin was recommended by someone who couldn't be here today, Don On from Catholic Health. He recommended him. He's like, he's going to be great. And Don really wants to know more about the Department of Health and building relationships with them. So we're so happy you're here today, Toyin. Thank you so much. I really appreciate it. And thank you, Frank. We look forward to your discussion. And I believe you're going to have time for maybe 1 or 2 questions at the end. So think about some good questions for these. Thank you.
Thank you, Lizzie, very, very much. We're glad to be here and appreciate the chance to speak with everyone today. So what we're going to do is try to give you some background on the State Health Department's regional office survey process. Toyin will be explaining a variety of issues. And if you're okay, Toyin, we'll dive right in. Very good. So starting off, just tying into the opening discussion from the commissioner, can you talk a little bit about how the regional office interacts with the New York City Department of Building process, and especially around items like certificate of occupancy, temporary C of O, and other forms of project completion that the department might accept, such as letter of completion and letter of no objection?
Okay, thank you so much, Frank, and thank you, Lizzie, and thank you, everybody for being here today. Permit me to quickly recognize somebody here today. She's from the Department of Health Regional Office. Her name is Nisha Shures Babu. She's been with the department for over, I believe, 25 years now. Nisha, can you just wave at us? Yes, that is Nisha over there. She is a seasoned sanitarian inspector, and she's been doing great work for the department, especially in the Maro region. Thank you so much for what you do, Nisha. I want to quickly dive in to one of the things we look for in our inspection process, and especially to schedule an inspection in the regional office, is a certificate of occupancy or letter of completion or letter of no objection. Most of the time, we've seen that document cause a great deal of delay because we cannot definitely approve any project without any of these documents. And we noticed that, it's very complicated in New York City because some projects, they get certificate of occupancy, some they get letter of no objection, some they get like letter of completion. But our advice will always be that we get to submit or to apply for this document early enough with DOB, knowing the backlog, so that we can get, whatever we are required to get from DOB, and then we avoid a delay. There is no shortcut on it. If we don't have any of those applicable documents, the project is not going to move forward. And that is the law, that is the standard with DOH. And all of these processes are laid out on the C.O.N website, Certificate of Need website, on DOH website. So you can, definitely familiarize yourself with those information. And definitely, if you familiarize yourself with the DOB website and some of the process that has been laid out by the commissioner this morning, one of the things we got to know that they just did in DOB to facilitate any of these things is the project advocate. They just started that program a couple of years ago, and it's been very helpful so that you know what you're applying for. You can, find out that information ahead of time. And then this will, make the project go seamless and you can get, whatever you need in time of CFO, letter of no objection, or letter of completion on time to be able to open your project.
Thank you, Toyin. One thing just to clarify for folks, if they achieve a temporary certificate of occupancy, that is sufficient to get through your process. Is that normally correct?
Correct.
Okay.
Correct.
Thank you.
And let me say something, because of the special or unique nature of our regional office, we cover Long Island, Suffolk County, Nassau County, and we cover Westchester and all the way to, I think, Middletown. We have different different requirements for each, of those areas. So those are very, letter of no objection, letter of completion are very specific somehow to New York City because of the unique nature of the 5 boroughs here in New York City. So that is the thing.
Thank you. So before we go through the process itself step by step to try to focus on specific areas, are there any new inspection focus areas or guidance that providers should proactively plan for from the department? And if not, besides what we just discussed about the interaction with local Department of Buildings, is there anything else at the top that you'd want to talk about, any other areas where people often fall short when they're getting ready for a pre-opening survey?
Thank you. I would want to say this. For the past couple of years or months now, we've been having this delay due to closure plans. And this is very important because here at the regional office, we've seen projects getting to opening, but because they have to wait for approval for closure plan, the project has been experiencing delay. What I will advise is this. If you have a project that is old, like 3 years old or 4 years old, and you are called into that project, take a look into that project and see if there's any element of closure, maybe decertification of beds, conversion of beds, or closure of services. And make sure you ask them if there is any closure plan that has been submitted or reviewed or approved. Because if we don't have that, the project cannot be approved. And we've seen delays in those approval process, because now, recently, some of these closure plans will not even stay at the regional office or at the central office. They have to go all the way to the governor's office. And you can imagine the kind of delay that we can experience if we have to go through those approval process. So it's very essential to look at those projects. If you see anything like closing service, if you see anything like decertification of service or conversion of beds or relocation of a service from one place to the other, it's very essential to get on it and to reach out to the regional office to ask if this is needed or not. And then we can definitely guide you to submit the approval, to submit the application to get the approval on time so that you don't experience any delay.
Thank you for that, Toyin. Also, I would add, and to note another person in the Metropolitan Area Regional Office, Fiona Biddle, your colleague, is terrific at letting you know what type of action you may need to take if you're contemplating a true closure, a relocation, a decertification, a conversion, and depending on the timing perhaps of when beds or services have been offline, there are different things. Fiona is terrific to be able to go to in a consultative basis where you're not saying that we are closing, you're not disclosing, saying we're closing, which then triggers a lot of actions you have to do. But with Fiona, you can say, if we are considering X, Y, or Z, what would we need to do? And I think that's a really important step to take before you tread down that path and to get in advance and not cause a delay for yourself down the line. So Toyin, let's run through the survey scenario now. So first, when providers are in the midst of construction, how far in advance of completion should they be reaching out to your office to schedule the pre-opening survey? And is there a difference in timing depending on the type of project, and also depending on whether the project maybe is, the major programs that the commissioner spoke about that may have phasing?
Thank you so much, Frank. I love the word you use, depend. That is our word in the business. This question really depends on a lot of factors and a lot of what is going on with each project. But my advice would be that if you're in the middle of construction, there is no crime in reaching out to us, the regional office, to say, hey, we have an approval for this project and we are expecting to complete our project so time. But we usually ask that you reach out to us like 3 months, 90 days, before the expected completion date, so that we can plan for the pre-opening. However, reaching out to us early or late will not necessarily delay your project, depending on a lot of factors. For instance, if you have a project at the time you want your project open, we might have to push it forward. And if your project is big enough that once staff will not be able to do it, we might need to look for days or time that we have ample or couple of staff available that will be able to come. Also, if you have a big project, like you are building a tower, you are building a new building and it's big enough, sometimes we come out, or you can request a courtesy, visit that, we want you to come during our construction to look at things, so that when you come for the final inspection, you don't experience a significant delay, during that time. So we do that as well. We can do like 75% if we have the time, can do like 90% depending on if we have the time, so that we familiarize ourselves all the way with your project. And when we come for the final inspection, there won't be any big surprise in code. And this will, eliminate all kinds of delay or anything that can, happen at that time. Also, in phasing out your project, we are very flexible with project phasing. When you have a construction logistics to, not to complete a particular project, at the same time, we are very flexible with that. All you need to do is just to call us and tell us what your situation is, and we review it and we'll give recommendation as much as we are allowed to do at the regional office. But we are very flexible in doing that. So the thing is, reach out to the regional office, like Frank said, reach out to Fiona or myself or any of the staffs like Nisha here, any of the sanitarian, and let them know what you are planning to do, and we'll be able to guide you appropriately, so that we can have like a smooth inspection and a smooth pre-opening. And also, I think Frank said something about, yes, to avoid delay. Also, I want to say that another area we've seen with project is when you are about, completing a project and some of the documents that you are required to have are not available, or we have a lot of back and forth with that. It's very essential for us to get ourselves familiarized with, some of those requirements of those documents. Sometimes we see a lot of documents that we reject, we send back and forth for like 5 times because they don't have what is expected for them to have in. So this could cause a significant delay, and it's very important to, proactively work on this and to, get the right documents so that we can move forward as smooth as possible.
Thanks again, Toyin. Just to highlight a couple of the things you said, all the regional offices, this one for certain, have had staff cutbacks over time. And so there are people in the room, although I might be in here on the longer end of the tooth. It used to be that 75 and 90% surveys were common. It's harder now with the number of people, But something Lizzie highlighted to, to Toyin and me when we were preparing for the session is that a good number of people have expressed the feeling of inability to communicate with the regional office. I don't think that's the case. I think what Toyin just said is important. You judge based on your project. NICECon now has made it easier. We're going to talk in a little while about the regional office tab, but and the environmental documents checklist. But they're certainly available for communication. So if you have a large project, we have a provider, I think is in the room, that had a 75%, and then we'll go to 100%. They don't need a 90%. I'm going up to outside the Albany area next week for a nursing home where the regional office up there, it's a phased project, and they're willing to come out and meet beforehand because it's a big project. They want to figure out with the provider how best to attack it. So I think that's the regional office here, your regional office is very available, and if you're in any other regional office, we see the same type of thing. So, Toyin, okay, so let's say we now have a provider ready to have the survey. They've scheduled with you. They have the environment all set, construction's done or mostly done. They've submitted the right paperwork. They have the other paperwork that's needed on site. Who do you want to be at the pre-opening survey from the provider and their contractors? And as part of that, you're touring the site, you're the environmental review person. What is too large a group? What is too small a group, if you can say?
Thank you for that. And, that's a very simple question, and it depends on the facility. We are quite flexible in the number of people or professionals that we want to see on a survey or inspection, as we call it. It depends on what the facility can, afford, number one, and number two, it depends on, the nature of the project. Take, for instance, if it's a big project and we are walking through, we might have a question along the way, maybe an engineer or electrical engineer, a mechanical engineer, or an architect. If we have that real person, or if we have that person, that professional on ground, it will be easier to resolve some of the issues that we might want to ask question about. And instead of waiting to get an answer, maybe the following day or in 2 weeks' time or 1 week time, is usually great to have an answer right there and then. And that will facilitate a lot of the process. However, if for one reason or the other a professional is not available, we usually, get our question across through the provider to their contractor or to their engineer, and they will get an answer to us. But usually, because the architects, they were usually from the beginning of the project to the construction time and to the end of the project, we usually want to see an architect with us during the walkthrough. And also, depending on the number of staff, we don't usually have any preference for, whether a large group or a small group. I've been to inspection, or we've been to inspection whereby we have just the provider there. And we've been to inspection that we have like 30 plus people working with us. When you go to this larger S system and building, they usually want everybody there, from the nurses to director of operation to building safety, so that if there's any question, they can answer us. Even though, you feel like, these people are too much, but at the end of the day, it's helping the process. So we don't have any preference. It depends on the facility. But know this, not because somebody is not present, that doesn't disturb the process. If we have any question, we get the question back, and then we get an answer ultimately.
Thank you. So I think the overall advice, and I can take an example of a phone call I got yesterday, is you need to have your professionals who are involved with the project available at least, probably your discretion on how many people you want walking around your hospital or your nursing home or your D&T center during a survey, but not having a person available. As an example, at about 8 o'clock yesterday morning, I got a call from a client in Buffalo, a hospital system, that had the department walk in. Their architect was not available. Fortunately, I could answer the question. It was C.O.N. related, but having people available when you know the department is coming is very important. So, and it ties into the next question, Toyin. So let's say now survey's done. You've left, you're going back, and none of us is perfect. So we can expect normally some statement of deficiencies. It may not be, how could you not have X, Y, or Z, but it could be small things. Whatever it is, it's normally something. How long does it generally take between the time the survey ends and the time the provider would see your written SOD? And then how long do they have to respond to that? Is there a set time frame?
Thank you so much. Very simple and very straightforward. You can expect to see our findings, we call it findings, in NICECON between like 7 to 10 days, business days. So because, when we come from here, we can have another schedule and all of that, but you can expect to see between 7 and 10 business days. We put everything that we have, in NICECON between that time. And we usually expect provider to do like maybe 1 week, 2 weeks to respond. But know this, the earlier we have your response, the better it is for the project to move to completion. So if you have the corrective action, I've seen projects that we go out and we do today, we put our findings in today, and the provider responded back today because the corrective actions are so minute and they do it quickly, and we approve the project the same day. So the earlier we get it back, the better it is. But to be very definitive, we can put our finding, you can expect to see our finding between 7 to 10 business days, and we expect the facility to have their finding or the corrective action back to us, between 2 weeks of going out.
Thank you. And things we talked about in the prior part of the discussion, if somebody's not available at the time of the survey, it can lead to additional findings. If someone isn't able to answer something that you asked during the survey in a timely fashion, it can delay you getting your report out. And then the other thing we'll say, I think a lot of people in this room know this already, but it's a fact. I think the regional office staff is roughly half as many as when I started maybe 25, 30 years ago. And you're a facility. Toyin is there seeing your facility today. Toyin may be seeing another facility this afternoon and may be out in the field seeing other facilities the next 3 business days. That makes it hard to get there's not someone sitting there, there's not another Toyin, and there's not 2 of him, and there's not another person sitting there taking the survey findings and converting them to paper for you. So the better you are when Toyin or Nisha or anyone else comes on site, the quicker you get to the point, particularly if you're changing your operating certificate, which we'll talk in a little bit, the quicker that will happen. So now, Toyin, you've sent the findings out. Someone submits a plan of correction, if you will, or CAPS, corrective action plans. They've submitted those. They've responded in NICECON to each one of the findings that you've posted. How long does it typically take? I know the answer is there is no typical in this. It depends on the item. But how long does it typically take to resolve any outstanding items? And more important, I think, is there anything providers can do to help improve the turnaround time or avoid delays? And what are some common mistakes that people make at this phase?
Thank you so much, Frank. I will start from where you ended the question. What provider can do to facilitate this process or the acceptance of this corrective action plan is to follow whatever the inspector put in NICECON and to address every component of that finding. For instance, if an inspector put like 2 findings or 2 there are two components to the finding and you only address one, that is not acceptable, and that would delay because it will take time for the inspector to review whatever you put there and to get back to you, say, hey, there is still one more outstanding finding to this particular item. So it's very important to avoid delays, to be able to respond adequately and to respond, acceptably, addressing all components of each finding that we are sending out. That is very important to, to get the process going and to get a smooth transition or true, smooth ending to the project. And I want to also say that when we are reviewing a corrective action plan, in the regional office, we've been very responsive to this because we know the nature of the business. The provider, they want to open, they want to start seeing patients, they want to do everything quick, especially when they are getting to the end of the construction. We understand that, but given the limited resources we have, we ask that, you send to us and you give us some grace time to be able to address your concern. And sometimes the inspector that comes to your project or that did your project might be doing something else, like Frank said, might be on the field doing something else right now. The person might not be able to get to that project. But if you wait like 1 or 2 days and you've not seen any movement on your project, you can reach out to Fiona or myself. Where, sometimes I go out too these days, but, Fiona is always in the office. She's the head of the Certificate of Need project in the Metropolitan office, and she will be able to get hold of any one of us. And if the staff that came to your unit or your facility is not available, I'm always a good backup to review whatever it is and to be able to help. Take, for instance, one of the staff is on vacation now and will not be back for like maybe a couple of weeks. I can stand in and review whatever is done that he didn't get an answer to before he left. So that is very essential. But the bottom line is communication. Reach out to the regional office with your concern, with your question, or you uploaded something. Take, for instance, you uploaded something and for 2 days, for 3 days, it's not been reviewed. Reach out and say, hey, I just want to follow up to see if there's anyone that can review whatever I've uploaded, and then we'll take it from there.
And to highlight the communication part, where our firm sees the most delay in finishing off a project after you've received your findings is, well, they asked me for this document. I have that document. I believe that document should satisfy this. If you believe that, put forth your case to the department, but bring it to someone's attention that you're not, don't end up in a case where you're going back and forth with documents. Keep trying to satisfy it with a different document. In the first instance, in most cases, I'm going to be wrong, you're going to be wrong. What they ask you for is what they need, and that'll get you to the finish line fastest. And you're at, as Toyin was alluding to, you're at the stage where you want to make that beautiful thing you've just constructed productive, starting to see patients, starting to have revenue coming in the door. Not generally not fighting what they're asking for, but if you do, put in your document, give a reason why you're giving that document versus what you were asked for, and then after a couple days, if it's not signed off on, reach out. Don't sit there and wait and say, should we give something else? Should we do this? Should we do that? Reach out, as Toyin said. Just ask the question. And if you lose the battle, you lose the battle, but you lose it sooner than sitting around for a couple weeks. So thank you for that, Toyin. So to the last stage. So our plan of correction, our caps are accepted, and we are now issued a letter saying that your project is now approved, effective this date. What is the process for the regional office to help close out the C.O.N. application in NICECON as complete? I call it a capital C because that's how it appears as the status. And if it doesn't get that status, sometime down the line, you're going to get a letter saying, whatever happened with your project. So you want that to happen. And also in some cases, you have a project that has an operating certificate that's changing. How do you work with central office to help have that occur?
Okay, thank you so much, Frank. That's very important because until that is taken care of, the project is not complete in a way and it's still open. But if you get a letter of approval from us that you can occupy, you can use the equipment, what we do from there is, I call it the back office. In the back office, what we do is to get all the paperwork together. We go into NICECON, all your approval from PMU, we put everything together and we send it to the central office to process the operating certificate. And the thing is this, I can tell you, I can assure you that we take that very seriously because we know sometimes the insurance company might be asking where's your original operating certificate for them to bill Medicare or Medicaid, as the case may be. So we take that very seriously. As soon as we approve the project, we get on it and we start the process. But like we all know, it's a process. The process of gathering the document together, we fill out the forms. There are a bunch of forms that we fill out and it goes through layers of review in the office because we don't want to make mistake. We want to make sure you have the correct beds. We want to make sure you have the correct services. We want to make sure you have the correct location and everything. And when we finish that, we send it to central office. And central office, we issue the operating certificate there and then. I've seen facility reach out to us that, hey, where is our operating certificate? And when even they finish from central office, it's still a process of dropping the operating certificate, in the USPS to deliver to the facility. That takes a time also. I've seen facility that they send, we requested a digital operating certificate for them so that they can have something at hand. So, but the thing is, we take care of that from that process from that point on when you receive the approval, and you don't need to worry about that. We take care of that from the regional office, and you will maybe like 2 weeks or 3 weeks, depending on the workload of the staff doing the operating certificate in the central office, you will get the operating certificate at the right time.
And that staff, there's really only one person who's dedicated to doing that.
Yeah, I wanted to say that it's just one person with the whole of the state, and you can imagine, the number of projects that we have. So she's really doing a fantastic job, given our capacity and the number of hours we have in the day. So yeah, just exercise our patience, and if you reach out to us, we let them know, we are looking for this. And
yeah, and something that Toyin mentioned, I will give to Lizzie the operating certificate unit's email address in case you want to circulate it to the group. But something that Toyin mentioned is important. If you have an operating certificate issue that is preventing you from getting contracts for reimbursement, the project management unit under which the operating certificate group falls will try to help expedite that. They look at that as an important thing for providers. So you can count on that. And there is only one person. She is not there every single day. She gets vacation. But they cover. There are other people capable of it, but it is one person for all 150 to 200, however many hospitals are left, 600 roughly nursing homes, and all the D&T centers in the state, all Article 28 facilities. And every change to every operating certificate is that one person. So, don't be the person who cries wolf. If you have something that's hurting you from an insurance standpoint, feel free. Otherwise, as Toyin said, it's going to take a few weeks. So Toyin, our last thing, we just wanted to talk a little bit about the environmental documentation checklist, the EDC, as some know it, the 48 items there, and we're not going to go through them all, and nor is there going to be a test later on this, but are there key items on that list you would want, since you're here in front of this group, to highlight for folks, a few key ones, and why don't you take that?
Oh, Thank you. And let me start by saying this. That checklist is designed to facilitate the opening of any project. And just know this, the 48 that Frank mentioned is not everything will be applicable to your project. Not everything. We are only looking for only applicable, document out of those 48. However, and I know it all depends on your particular project. Like I said before, if you are operating from Long Island or NASA or Suffolk or Westchester, Orange, you have different requirements for some document. And if you are in New York City here, you have, different procedure or different process to get some of these documents. But I just want to quickly mention that we've seen delays in some of these document, EDC we call it, Environmental Documentation Checklist. We've seen for instance, document number 3, record of fire alarm completion, document number 4, sprinkler system. We've seen that a facility will just write a note and say, okay, it's completed and all of that. If the checklist actually says that a form should be attached to it, there is no two way about it. We are looking for that form, and if you don't see that form, it will be rejected. So the guideline is there, and to some of us who doesn't have the document is available on C.O.N website, you can get to print. It's a public document so that you can familiarize yourself with it. So those are very important, like record of attachment from NFP 13 for material and contracting. If you don't attach it to it, we are going to reject it. Another big one will be the EDC 19. If your facility is a facility that is required to have a type 1 electrical system, the engineer must write that letter and certify that you are compliant with type 1 electrical system, and also you have to attach the listing of functions. Listing of functions like these are life safety listing functions, these are critical functions, these are equipment functions. If you don't see those, we might reject that particular EDC. And we are looking at that because we might not be able to see every panel when we go on site. But if we have that in advance, we'll be able to look at it to see if you have a particular problem with whatever it is there. We'll be able to address it on time. And also, we have a DOB is very important. Also, if you don't have that document, we might not possibly schedule an on-site inspection because there is no need. It doesn't make sense for us to come out when we know that you are not going to be open or you are not going to be able to occupy the building anyway because you don't have a certificate of occupancy. So that is very important. And also when we go to medical gas system, the installer might be a professional, might be an excellent one, but if they have an expired certificate, we are not going to be able to approve whatever they put there because they are not operating undercover. They are not authorized to operate. So we are looking for their current certificate to be able to install those medical gases and all of that. Those are very important. And also we are looking at the balancing report. That's a big one also for EDC 29, balancing report. Whatever the report that we have must be accompanied by a certification by a design professional, engineer, architect, who will review or who must have reviewed those figures and certify they are in compliance with, whatever FGI edition that you use for the project is very important. If you don't have that certification letter, we are not going to move forward with approving the project. And I want to say this also, sometimes if you have like few documents, you can actually break them down. If they are not going, if they are too large and they are not going, you can break them down, you can upload them, in pieces under each item. That is very important. And last but not the least will be the EDC 44. I think the floor plans and the life safety drawing is very important. I usually look for that before I go out, and so all my colleagues also, because we want to see in advance what we are looking at, and if there's any problem, potential problem or any problem, we can, get across to you beforehand so that we don't experience any kind of a delay. So those are very important. And if you have any question about any of these EDCs, what we are looking for, maybe you are confused about something, because we know sometimes it could be complicated. Sometimes the contractor will be telling you something different from what we have in the EDC. You can reach out to us as well, any of the staff, and we'll be able to guide you appropriately on what to do and what to submit.
Thank you, Toyin. Lizzie, do we have time for questions, or do you? Okay.
So I'll ask a quick question. I think arguably for us, I think arguably for us, one of the biggest challenges with the EDC is FDNY, and getting our letter of completion from FDNY to open the facility. And I know that the department has gone back and forth over the years about accepting letters of defect for approval when there are minor things that FDNY is requiring, giving us the permission to occupy from their perspective, but giving us a letter of defect to fix a couple of minor things. What's the current standing with you guys now from a letter of completion versus a letter of defect to be able to open facilities?
That's a very good question. Permit me to ask Nisha. Nisha, do you want to speak about that? Because she's yeah. Yeah. Sorry, I put you on the spot.
Thank you. So if it is an existing building with an existing system and you're just upgrading it, and you have a letter of defect, usually, and if you have the building department approval, which is your TCO or the letter of completion, we do recommend provisional approval, pending the letter of defect does not have major defects. For example, I'll give you an example. Sometimes, FDNY requests the riser diagram to be resubmitted, or some minor defect that they find about a smoke detector missing by the enunciator panel of the fire alarm panel. Some of them are vague. Some of them are vague comments. I agree with that. But there are some. No. Generally, I have seen certain, exact points of what the defects are. There are vague comments. I do agree with you fully. But when there is somebody who's in the facility who's walking with the FDNY inspector, so they come to know what exactly the problems are. So. Right. So most of the times when I see those vague comments, I do go back to the facility and ask them, what was this about? All right. Yeah. So when they can give me exactly what the issue is, we determine whether it is a major one or a minor one. And usually, in the past, building departments never accepted or approved the premise prior to the FDNY approval. But recently, that has been disconnected. The FDNY does their own thing, buildings do their own thing. So, since we have the TCO or the letter of completion from the building, and if this is a minor defect, we do recommend provisional approval. And most often what we see is that the EDC number 3, the fire alarm system record of completion, is never submitted before the FDNY approval comes in. So that's the pending document that's always there on our side when you do not have the FDNY approval. Am I correct?
Thank you, Nisha. And I want to add to what Nisha is saying. If you have that kind of complex situation, please reach out to us. We evaluate the case, on a case-by-case basis. We approved a project recently in the Bronx. They are located in a kind of a mall, right? And the fire alarm system for that particular building is working operational. But somewhere in the mall is tied together, and somewhere in the mall they have deficiencies. And they cannot have the final document until everything is rectified. So what we did was, we discussed together, we, analyzed the risk and the potential risk associated with not having this letter from the facility, and we went ahead to, we made our decision based on what we, see realistically about that particular project. So if you have that if you find yourself in that kind of situation, at least give it a try, reach out to us, and we'll discuss together in the office, and then we'll get back to you. The goal is to make your facility very safe and to save for the staff, for the patient, for everybody. So, and that is the same goal we are working towards. So if you have that kind of situation, reach out to us, and we'll be able to, advise you accordingly. And if there's anything we can do, we'll let you know at that point in time.
Wonderful. I think we're going to wrap up here. Thank you so much, Frank
Thank you.
and Coyan. We're going to take a 5-minute break, stretch your legs, get some coffee, come right back. Then we're going to have a specialty session. That's my term for it. The intersection of innovation and accountability with moderator Sean Hutchinson, Tom Singh, Christine Hillman, and Frank Rudiloso. Thank you, Lisa.
My wife does that to me all the time. Well, usually for the kids.
Hello, everyone. Please take your seats for the next panel discussion.
First, she was just here. Square it up. In between stage.
So about a year ago, Andrew Weinberg sent me an email, and he goes, I think you would be interested in this. And it was a presentation about Montefiore's decision and process of taking their entire real estate portfolio and making a digital twin, which was so interesting. So I brought it up to the committee, and Sean latched onto it. He really knew how to take that information and extrapolate it into what we were trying to do in connecting with the regulators. And he's like, data. How do you earn trust about data in this age? And so he quickly put this panel together. He invited Christine Hillman from Montefiore, who seems to have momentarily disappeared. Hopefully she'll show up. She was here. She was here. So we just, oh, okay. So she's, oh, yay. Okay, so Christine, and then apparently these four all worked together at NYP back in the day. So they're very collegial, brother-sisterly vibe here. And I'm going to let Sean take it from here. Just a reminder that everyone's bio is on the back of this sheet. So if you'd like to read more detail about the background of all the speakers today, it's right there. Thank you so much.
Thanks, Lizzie. And before anyone notices, I had a sniffle, so if I sound congested, I'm not contagious, I swear. But exactly. So thank you, AIA and AMFP, for giving us a stage to discuss what I think is a really important topic. As I've seen the evolution of a building information model turn into X, turn into a digital twin, when the topic was brought up, I thought it would be a great opportunity to get the regulatory story together. So the only introduction I'm going to make up here today is Mr. Singh over here on the end. For anyone that knows him from New York Presbyterian, that's not who he is today. He is representing the Joint Commission. We have it in writing, so we're good to go with it. But no, really, I just have to say what a personal honor it is to be up here with these folks. Over the last 20 years, I've worked alongside and helped represent sometimes the great work that these folks do. And without the due diligence and the grit of how they approach their roles, the environment of care just breaks down. Because healthcare facilities are crazy hard, right? I mean, you take some of the most jam-packed facilities, some of the most complex infrastructure, you put that together with vintages of buildings that go back decades and sometimes centuries, and all of a sudden you have a very, very difficult understanding of where you're at today. At New York Presbyterian, 51,000 employees support the mission of providing care for 2 million healthcare or 2 million patients every year. And Montefiore Einstein is similar. Christine, you sent me the notes, but I didn't see them yet. They are shaped by all the decisions that are made very, very early on that we have to leverage for the entire outcomes of these facilities. So all you architects, engineers, CMs, George that's out here making decisions early on, George, right? That becomes the foundation for the operators of these facilities for decades and hopefully centuries to come. So it's really important that we get that right. And one thing that I learned very early on working on the owner side is that what we believe we know about a building is totally different from what we can confidently say is true today. And that's really what this conversation is about. And I'm sorry, I'm going on my notes because I don't have a very good memory anymore. But and I'm going to turn it over to Frank. So Frank, what's hardest about maintaining confidence in your understanding of a facility? And don't say budget, but we all know it's budget.
Okay, thank you. All right, so I think confidence comes from clarity. We cannot be confident if we don't know whether we're looking at the full picture. Healthcare, as we said, is highly regulated, very complex, every day changing, and without strong systems, cross-collaboration team members, and data clarity, we don't really know, and we continue to be a reactive organization. And we're trying to move away from that. It does start with a strong data foundation, our data standards, from project handover is the start. So we need to know what the data coming in is and be confident in our systems, because garbage in, garbage out, we don't know if we're actually doing everything that we need to do. And without that, all of that, one person cannot be confident in the systems that we have.
I like to say I started that data handover at New York Presbyterian.
That's true. Thank you.
Yeah. So and so it is data, right? It's data, but it's also people.
Yes.
So, Tom, I want to go to you next. And again, this is Tom with his Joint Commission hat on. You're going out to facilities. Maybe you've been there before. Maybe it's your first time. what gives you confidence that the operators of that facility know what they're doing?
Sure. So first of all, thank you for having me. It's a pleasure to be here on behalf of Joint Commission. If you don't mind, Sean, we're going to go a little off script.
Sure.
We didn't plan this. And if you don't mind, I'm going to invite additional people to be part of the panel, if that's okay with you. So I'm going to ask the audience some questions. And that will feed into the question that you just asked. So how many of us have been part of a Joint Commission survey in the past? Walk with the surveyor. Okay. They used to be called JACO, right? I think some of us still call them JACO. They're the artists formerly known as JACO. They rebranded. They used to be called the Joint Commission. They dropped the at the end of last year. So now it's just Joint Commission. For those of us that raised our hands, when a surveyor arrives to a healthcare facility, what's the first thing that surveyor asks for? Anyone? This is the panel by extension. Statement of conditions. Okay. What specifically in the statement of conditions are they asking for? Life safety drawings. So the first thing they ask for is life safety drawings. Why is that important? Anyone? Christine wants to answer this, but we're going to open it up to the group. There's a hand in the back, all the way in the back. Navigating through the survey, understanding the building, right? Those life safety drawings are required to have certain elements and features. So there's fire barriers, smoke barriers, compartmentation. All of those features need to be consistent with what edition of the Life Safety Code? It's not the latest. Don't answer it, Frank. Why 2012? Ryan, why? We are in 2026. Why 2020? Why 2012? You have no idea. Can anyone help Ryan answer that question? That code is about 13 years or so. Sorry? Correct. So the Centers for Medicare and Medicaid Services have adopted for healthcare facilities the 2012 edition of the Life Safety Code. So Congress has to approve the next edition. So as a surveyor, I get this question a lot. How come we're not on the latest edition, 2018, whatever it is, the latest edition? And that's because it goes through Congress. So all of those features, smoke compartment size, 22,500 square feet, suite size, 5,000, 7,500, 10,000, all those elements need to be part of the life safety drawings. That, as a first question, helps surveyors get the confidence that the facility is aware of its portfolio in terms of life safety features, elements, and things like that. One more question before, Sean, I turn it back to you. So after the life safety drawings, and thank you for your answer on statement of conditions, what's the next thing they ask for? This is all the first hour of the survey process. Kevin, that was a good answer. Right before inspection records. They want to look at certain things. What do they want to look at? Okay, so I'll help you out. So I'm going to use this analogy, Sean. A building, to me, is similar to a patient, all right? So we can get into the engineer design of a building and how there's similarities with the anatomy of a human body. We can get into that, but George, I won't get into that for this discussion. When a patient goes to their primary care physician, one of the first things that the physician may look for are simple vital signs. So from an engineering and architect perspective, when a surveyor arrives at a facility, they look at the drawings, right? Then they want to check the vitals of the building. What are the vitals of the building? Systems. What systems? Specifically, what systems? Yes, so it was mentioned earlier. Some of this was mentioned earlier. The EES is one, someone said fire alarm. First location is a fire alarm panel. The reason for that is, let me just get a sense of what's happening in the facility, Sean. If there's any troubles on the panel, explain to me what's going on. Simple vital of the building. The second location is the emergency power supply system. Are the generators kept in working condition? Are the automatic transfer switches properly labeled? Are there separate branches of emergency power? And then the third location, the fire pump. If that fire pump is being kept in accordance with the NFPA standards, well maintained, the drips per second per manufacturer requirements, things like that. So all of those elements come into the survey process. And to answer your question, Son, if a organization can successfully walk through those elements during a survey process, that shows confidence to a surveyor. Thank you.
That was my answer to all those too. That was exactly what I was going to say. So we're talking. This is great because it brings us to things, right? Like assets, like the stuff that Christine's pretty much an expert on. So, Christine, what are your biggest challenges as the facility evolves? What are your biggest challenges with maintaining that asset information?
Sure, great question. First, I'd like to say thank you and hello to everyone. I'm really happy to be here with you. By the way, I knew that Tom was going to do that. I've spoken with him before. I've never spoken at a panel, so please bear with me while I look at my notes. For one thing, I'd like to set the stage at Montefiore Einstein. It was a multi-year project to transform and bring together asset management across 13 hospitals and 1 university, Einstein. We had 38 disparate systems, 38. We do cover clinical engineering as well as facilities engineering, fleet, and radiation assets. So it was a multi-year project. It resulted in 1,000 users, 1 main system for asset management, and we do have a companion system for visual asset management. We know that it's a culmination of cross-entity function, and it's the first in its kind in our regional healthcare area. One of the biggest challenges is maintaining the assets across the system is because it's inherently dynamic. We know that things change all the time. Specifically in clinical engineering, the equipment itself moves, it's mostly mobile, but with engineering, changes due to construction, regulatory changes, needs, right? So it's a matter of constantly being able to keep that information up to date in real time, specifically for the assets, and in near time for the construction, the visual asset management, the visual portion of that. So basically what we put together was a digital twin, and we keep that current, for our spaces and our assets. We like to keep that up to date so that we can, instead of having scattered drawings and disparate systems of assets, we have one single source of truth that is standardized. We standardize our assets across the health system according to ASHI's class and category. So we have one standard. And with that, we're able to know that we are managing our risk, we are compliant ready, we're able to go through an audit, and we're able to make decisions in real or near time.
That's outstanding. Yeah.
Yeah, can I'm gonna plug the data standards here, even though, so as the chair of the ASHI Data Standards Task Force, it is available to everyone. We're continuously developing this and trying to evolve this, and it's meant to help an organization from small to large. So it's out there. Please take a look at it. If you have any questions separately on that, let us know.
So we did adopt that at Montefiore. We've made some changes, but it's working out really well for us. In fact, I think you're going to start up the cohort again, and we'd love to share those changes with you.
Yeah, so, it's not just setting up the system, right? It's maintaining the system, and it takes continuous effort. Like we said, the hospital's evolving, the equipment's changing out. So, I want to go back to Frank. You guys are trying to get your arms around these facilities. So what helps you maintain that long-term clarity? Is it, I know New York Presbyterian hasn't officially moved towards looking at digital twin, right? Or am I wrong there?
We're looking. Because, as mentioned, right, we have a lot of different systems. And it's hard to maintain each system individually and not look at them together. Digital twin would bring that all together visually and to use it, right? So we talk a lot about data, collecting data, but we are trying to move towards data intelligence, right? How we use it, not just get reports. Because you get a report, do you read it? Do you know what to do with it? We're doing a lot more right now around reliability-centered maintenance. A few years ago, CMS has allowed organizations to adopt alternative equipment maintenance. So rather than doing just time-based maintenance, do it because that's what we did, change filters 4 times a year, 2 times a year. We're really going towards the reliability avenue. And with that, you incorporate things like vibration analysis. And we're looking at fault detection diagnostics. And we're looking at how we pull vibration data into the FDD so we could look at things simultaneously. Digital twin, some are doing it and are further advanced than us, but it's a big thing to wrap your hands around, but it is looking at all of those different pieces or systems that we have so we can get a clear picture. We still need people, right, and processes, because we can have the best technology and not know how to use it or not have the right people, and then it's just technology that sits there, right? It continuously has to be updated. We have to continuously educate our teams on how to use it and to share that information.
Absolutely.
So if you wouldn't mind, if I could add.
Sure.
So we scanned over 8.5 million square feet for Montefiore in the hospitals and the university. We did not do our offsites yet. And we did that through traditional data collection with standards and processes, and then we matched that with our scanning and we mapped the assets to our digital twin. But I just would like to throw out there that the next phase that we'd be looking at, and it is about the people, but we are looking at AI. We use the machine learning for our scanning to create the model, which is wonderful, affordable, doable. But in future, our next phase is to do scanning where we're capturing the assets with AI and with machine learning, and to be able to eliminate that data collection that happens, manually in the field. So that's the next wave. I'd just like to add that wrinkle.
So, want to tie this back to regulatory. So, Tom, early adoption has never really been a very safe place to be, right? So, I know we're not going to put you on the spot here. But you will. Yeah, but we're going to try to get an answer out of you. Is Joint Commission looking at using data from digital twin to certify facilities? Not now, but in the future.
So the discussions involving the use of data and technology are evolving with the Joint Commission and the central office. I will share within the realm of the physical environment, so that's facilities, engineering. Nationally, it's behind. Most organizations have not yet scratched the surface with the technology that's available to maintain compliant facilities and assets. I think in New York City, if we look at New York as its own little kind of hub, I think we're probably further advanced in that sense compared to the rest of the country. But nationally, with what Joint Commission is observing with healthcare organizations, not so much yet.
So I always like to finish off thinking about people. So that being said, I'm going to ask the same question to each of you. With your hat on for this specific conversation, Frank, what roles and skills are you seeing the biggest need for in the future? That's the gaps that we're seeing.
No.
Well, I think there's always a need for many roles, right? The facilities team has to run the facility. We need strong leadership. And I think as we talk about the digitalization, right, and I kind of mentioned, we may need to see more roles around that, right? Who can analyze the data and help drive that with the facilities teams. We're very, facilities teams, right, they are dealing with day-to-day emergencies, running a facility, we're dealing with regulations. We're lucky enough to have kind of 2 dedicated teams here. I have a team of compliance coordinators who handle all the Joint Commission documentation. That Tom Singh, who's not from Joint Commission at NYP, his team audits us constantly. And without those team members, we're there to support the facilities team. And we need more of those. A lot of organizations do not have that support. We need that support team so that we can let the facilities teams do what they're to do the day-to-day, be technical, run the facility, let every other roles help them maintain it, and then push also towards, we're talking about reliability. We need maybe reliability engineers, those individuals who can understand digital twin, right? One of our concerns in looking at digital twin is who's going to maintain this? Who's going to be able to understand the data that's coming in there to help our facilities teams? We can't take the facilities team to do it. They have a job to do. So I see more roles of that nature are going to be needed to help us to maintain that.
Absolutely. Christine, same question.
Same question. Okay. So we know that healthcare facilities is defined by people. We need people that can operate in the intersection of technology and strategy. I believe we need hybrid thinkers who can serve as a bridge between teams. We need to be able to work between interdisciplinary interfunction. We need folks that are comfortable with analytics, right? Dashboards and mobile digital work management, and using real-time data to make decisions. We need digital integrators. We talk about people adopting digital twins, Internet of Things, and all unified platforms. We need people that are connected to this technology and not just how equipment works, and people to ensure that they will keep this information up to date, like Frank has said, and certainly collaborators. I think the time of facilities working in silos is over, right? The gap between design and construction and facilities has to narrow. That's a no-brainer, but it's greater than that. It's procurement, it's supply chain, it's our business strategy groups. So I think you really have to find those folks that are able to work in an analytical environment, use the data, be a data-driven, we all talk about data-driven organizations, but really data-driven people that are collaborators. And it does come down to the people using that technology and keeping up with it.
Sure. So from a Joint Commission perspective, I agree on the data-driven analysis and driving people to feed that information, maintain that information, checks and balances, as Frank mentioned, for quality assurance in terms of internal readiness. If I look at the industry at large in facilities, there's fear when it comes to technology. Am I wrong with that? There is a sense of fear. What is this technology? How does this technology benefit facilities operations and engineering? How does it benefit the day-to-day work that's done by our facilities partners? I think one of the barriers that I've seen is breaking through that fear and understanding how technology can benefit the day-to-day operations and improve efficiency and compliance, because we don't really tie in the second component to that often. So from what I've seen, once again, nationally, probably not so much on the data side and the use of technology and integrating that in maintaining inspection, testing, and maintenance records. But in New York, I've seen a far shift in that direction with, again, professionals that are supporting those initiatives.
Yeah, so one thing I would say is that I did invest a lot in change management consultant, huge investment. I will never do a project, big or small, without that. It was really a key. It really works with that people with the fear, managing what the change impact is, having change agents, and really being able to measure the adoption. So I cannot stress enough the people element and really employing change management consulting for the communications and for managing all of that.
Yep, outstanding. So, I mean, that's really the story here. I mean, that healthcare facilities are more than just buildings. They're places shaped over time by the decisions people make and the work they do and the responsibility they carry forward. Every hospital reflects decades of design, construction, and operations and care, all layered together in service of the people who depend on it. And ultimately, compliance, safety, and confidence don't live in drawings or in systems alone. And I'm reading all this because this was Good. They, they, they live in the people, in the architects and engineers who create these environments, in the builders who bring them to life, you know who you are, and in the facility teams who sustain them every day going forward. Our responsibility collectively is to ensure that understanding carries forward, that the knowledge doesn't reset with each project or each generation, but continues to strengthen over time. Because long after we've all moved on, these buildings will still be there and they will reflect how well we understood them. Please join me in thanking Frank, Tom, and Christine.
Thank you.
I have so many questions. Does anyone else? Do we have time? What? So Tom, forgive me, and maybe because I'm distracted as I'm hosting today, trying to take pictures and everything, but did you really answer the questions? Like he was like, "What? Do you have confidence?" And you turn to the audience and ask the audience a bunch of questions. Do you have confidence in the technology? And like, so say Christine is like, "Oh, you want to look at my my fire panel? Look at it online. Click on these buttons." Like, would you be cool with that? And forgive me if this is like an inappropriate question. If you have a more intellectual question, please ask. So, but I just wanted to get some like really nitty gritty.
Yeah, thank you for your question. So I'm going to give you the same answer that C.O.N gave earlier from the Department of Health. It's 2 words. It depends. So it depends. Yeah. So, C.O.N, thank you for the answer. It depends on what we are referring to. So reliability of data, right? So field surveyors are required to check the actual utility systems, how they're being maintained. And that the best way to do that is actually putting your eyes on the piece of equipment, seeing how it's being maintained, because you can always check something remote, like let's say on a BMS system, a building management or automated system, to check the status of equipment. But there's other elements of the equipment that surveyors need to assess that are outside of that electronic system. So for example, this was brought up earlier. The fire panel needs to have a smoke detector, right? Protecting it. The other option for that is the fire rated enclosure and the constant supervision. You can't see that on a building automated system, right? The data won't show that. Even if the data did say that there is one, we would have to field validate that that is the case. So field conditions for surveyors is always first and foremost. In terms of inspection, testing, and maintenance documentation, I've seen that shift where we are moving as an industry towards electronic documentation, relying on dashboards as a starting point to capture the results of those activities. But again, surveyors have to drill a little deeper and see what the actual testing records are certified by those vendors that perform those activities, as well as take a representative sample on the field to see if those assets are being properly maintained. So that's the answer. You're welcome.
So, okay, I'm asking just one more question. Oh, someone else?
Do you believe that do you believe that the Joint Commission is actually looking into the future of implementing and going fully with AI for this type of stuff?
Yeah, so I will say that Joint Commission, so every year, Joint Commission holds its annual conference. It's every year in January in Chicago. Don't ask me why January in Chicago, but that's what happens. Yeah. But AI was a focal point of the conversations with the leadership team and the field surveyors, and how AI can be used to be incorporated into the survey process. So those discussions are evolving. I think on the clinical side, it's probably a little more advanced and further along than it is on the physical environment side, but there are discussions on how, I'll give you an example. Inspection, testing, and maintenance records, that's currently viewed at the hospital. You look at the records, things like that. I'm not saying this is going to happen, but this is a thought. If that information is uploaded to, let's say, a SharePoint site, and then technology does the first pass and notifies a server, these are the things that you probably ask questions about when you get on site. That's one way that AI can be used to make the survey process more efficient.
Do you think when the 2026 or 2028 standard, based off right now we're working off 2012, right? that will help the process and they'll implement more AI to make that happen? That's the thing.
You're asking if the adoption of newer editions will make AI. I'm not sure if the two are necessarily related in this case. I will say that Joint Commission recently published their what they call Accreditation 360, which is the revamping of the Joint Commission standards to make it more streamlined and efficient. Essentially, this is what happened. I'll give you the quick summary. Within the physical environment chapters, the environment of care, and the life safety chapter, there were, actually I'm gonna ask the question because you're looking at me. How many elements of performance were there in the environment of care and life safety chapters? How many? Throw out a number, any number.
48.
Way more than 48. Keep going higher. More than 200, keep going higher. Less than 1,000. Physical environment.
Just tell them.
Okay, 466. 466. Elements of performance. I may be off by a few, but not by much, right? So let's say around 460. That has been streamlined to 50. 50, one chapter, so it used to be two chapters, environment of care, life safety. Now it's one chapter, physical environment, 50 elements of performance. There's also a separate chapter, national performance goals. Within the national performance goal chapter, there's another 14 elements of performance. So we went from 460 down to about 50 or 64. That's one step closer to making survey process more efficient. Incorporating AI and technology is subsequent steps to happen. Yeah.
So may I add to this? So Tom mentioned the 360 accreditation change, and I mentioned earlier that we put together our assets for the 13 hospitals to standard. We also standardize our inspection, testing, and maintenance plans. So we have about 500 shared standard procedures that are aligned to code, where they apply. We also have site-specific if you need something specific. So when this change came up this year, because of the work that we had done to unify the system and to standardize our ITMs, we were able to go in and update our 400 or 500 procedures to the new references for procedures fairly quickly. And that's one of the benefits of standardizing in that way. Within 1 month, we were able to make that change within our system.
We have time for one more. George has got the mic.
So I happen to know that Northwell and New York Presbyterian and Montefiore are using different variations of the ASHE standard. What I think is a long-term goal is to look at failure rates. For example, I'm going to use a simple example of exit time. If we can show failure rates throughout the enterprise for people that use the ASHE standard, we can prove to NFPA that we don't need to inspect LEDs at exit time monthly. Or we can do a risk assessment if one's have failed. Even more so, when time goes to a facility and they say they use the ASHE standard, it narrows down familiarity with data, and really is powerful from a competitive benchmarking point of view, right? So, that's kind of where the idea of standardization long-term is going. So.
Okay.
It was a statement more than a question, I think.
Is there
I think you're proposing something.
Sorry, was there a follow-up question?
He's proposing. He's making a proposal.
But do you agree with that? That's probably the question.
Yes, and the ASHE Regulatory Affairs Committee looks at these things. We've looked at changes to, for example, fire extinguishers and later additions because of the data that was submitted. Same thing with that, but that will help them to easily collect data if it's standardized, which is your point. So yes.
Okay, just a question, Christine. Like Tina Masika, like your colleagues in the company, are they using the digital twin?
Oh, yes. There was some instant rejection. We're not using that. I don't know why. How are you going to maintain it? That's really the sticking point. How are you going to maintain that? People didn't want to buy into it. First of all, I was part of a huge ERP project. I knew we had the money. We could throw the money at it. I said, let's do it, and then we'll figure out the rest later, right? So they are using it. They are by and large using it for the planning, the feasibility, the concepts. We're sharing information with architects, not just our 2D files, but also access to we have all of our data, tabular data, and the model data. Folks absolutely adore that they do not have to walk to space. You do not have to walk to across campus, multiple buildings, big changes. We also did the photography in the 360 panos, so folks can search the entire room. What is the condition of that room? What does it really look like? Now, of course, all of this is a point in time. I will tell you that most of the drawings that folks were looking at were about 10 years old. You know, things don't get updated. So this is giving us the true baseline, true accuracy down to less than a square inch. In the beginning, we had a little bit of quality issues. We fixed those. The technology has improved. The scanners have improved a lot in the last 5 years, so highly more accurate. But folks are using it. Folks from multiple departments, not just design and construction. Yeah.
Awesome.
Yeah.
Thank you so much for that. Thank you for the whole panel. It was really amazing. I just want to quickly share some information about AMFP with everyone. Our mission to be the hub where healthcare built environment leaders share ideas, gain knowledge, solve challenges, connect with peers, and shape the future of the industry. I think we're doing that today. So yay for that. We have a lot of members for such a young chapter founded by Andrew Weinberg, who's here today. We have 22 healthcare systems as members and 300 companies represented. These are all, logos of the health systems. We have some upcoming events on the 26th and March 24th. You can, and the awards gala, which is a must go to on July 15th. You can register for these programs on the website. Thank you to our sponsor for today, Consigli. Thank you to our annual sponsors who make all of these programs possible. Thank you, thank you, thank you. And we do have new members. We have an awesome advisory board who helped me with this program today. You could see the high caliber of professionals who are on the advisory board, and I had a call with them twice to flesh out ideas for this program. So there's a lot of really quality dialogue amongst members. Our board members, and we hope that you'll get involved. On the handout, there's contact information for myself and Elizabeth Sullivan if you'd like more information about the Advocacy Committee or the AIA Design for Health Committee. And if you'd like some membership information, I'm on the membership committee as well. So feel free to reach out to me for that. And I hope you all have a great day. I will send you a follow-up email with some information that was discussed at this event. And thank you again all for coming.